Good. Dr. Fraser Gibb is an endocrinologist from Edinburgh. He's one of the topmost endocrinologists in Lothian, I would say that one. So I think it's more discussion about the parathyroid medical aspect. Here you go.
Very much. Yeah, perfect. Good. Thank you very much for inviting me to speak. All working? Yeah, so what I was going to do today is run through the diagnosis of primary hyperparathyroidism, some of the evaluation biochemical and imaging, treatment options and monitoring, and referring to the NICE guidance from 2019, some of the recent literature, and also some of our experience from a cohort of individuals that we've worked up over the last few years and published on. Doesn't seem to want to advance my slide here. Well, there we go. Yeah, so talking about presentation initially, one of the things that we found when we looked at this is that actually there's a big issue with delayed diagnosis. And so about a quarter of our patients had a significant delay in the first elevated calcium and then the first check of parathyroid hormone. And that's just shown in the table here that actually 12% of people waited more than 5 years between an elevated calcium and PTH being checked. And almost 40% of those ended up having surgery. So this isn't people where it made no difference. These were people where there was an opportunity to intervene earlier and that was missed. And similar findings have been shown in the United States where in one cohort only there were around 31% of people. PTH was only checked in 31% of people. So I think this is one of these areas where help in terms of automation and labs giving advice directly on what blood tests to do would be helpful. The NICE guidelines are useful, I think, for primary care in terms of telling people when to think about referring. They look at consistently elevated calcium levels and that key thing of looking at PTH and seeing whether it's suppressed or whether it's mid-normal or elevated as guiding you towards whether you're investigating malignancy as a cause for hypercalcemia or whether you're looking at primary hyperparathyroidism. And they'd also consider things like symptoms of thirst, polyuria, constipation, history of osteoporosis, history of fractures, history of renal stones, and also what they describe as undifferentiated symptoms, because as has been mentioned earlier, almost anything can potentially be a symptom of hypercalcemia. The previous speaker had also alluded to so-called normal calcemic primary hyperparathyroidism. I'm going to show a lot of graphs and tables in this talk, but you don't necessarily need to hone in on the fine detail of them. And essentially what is shown on one side of this slide is that if you check calcium often enough in people with so-called normal calcemic primary hyperpara, most of them will at some point have a frankly elevated calcium level. And also this appears to be a kind of intermediate phenotype. So it's not, there was a worry, I think, that normal calcemic primary hyperpara might actually be quite a severe manifestation. But actually, the biochemistry is intermediate and the bone mineral density, bone turnover markers and vertebral fracture risk actually appear to be very similar to controls. So I don't think this is necessarily something that we need to worry about as much as perhaps some people have suggested. And another thing we get referred commonly is the idea that someone has a borderline calcium level, an elevated parathyroid hormone levels. And a lot of the time, actually, what this reflects is vitamin D deficiency. But even when vitamin D levels are normal, I think it's also important to look at dietary calcium intake, because that is the key driver of parathyroid hormone levels is calcium. And the slide here is essentially showing that if you give a load of calcium to individuals, you will suppress their parathyroid hormone levels. So people with insufficient dietary calcium and a calcium level that's in the mid to lower part of the range, I don't think that's normal calcemic primary hyperpara. I think that needs to be considered dietary calcium deficiency or vitamin D deficiency until proven otherwise. And you can check that with giving calcium for a while. On the right-hand side, it's just results from the Nurses' Health study, which looked at different quintiles of calcium intake over a long period of time. and essentially showed that women with the lowest calcium intake over a lifetime had the highest risk of developing primary hyperpara. So just this idea that it's a driver over time for parathyroid gland hyperplasia, and eventually at some point the development of primary hyperparathyroidism. In our own cohort, we looked at presenting features in terms of symptoms, fractures, renal stones, and the percentage of the various symptoms are described on the slide here. You'll see that there are a lot of symptoms that are, I think, very difficult to attribute to this condition alone. Fatigue is extremely common. We see lots of people in endocrine clinics that have fatigue that has absolutely nothing to do with calcium or indeed thyroid hormone. And likewise, bone and joint pain are very common in the population as they age. What we did in our study was looked actually at the calcium levels where these symptoms were present or absent. And really the most discriminatory symptoms there were polydipsia and polyuria, where you actually saw a significant difference in calcium levels between one and the other. And looking at parathyroid hormone levels, the only symptom in which there was a significant difference between parathyroid hormone levels in this group of patients with primary hyperpara was polydipsia. So I think those are symptoms where it is actually worthwhile focusing in on. Do people have nocturia, polydipsia, polyuria? Those are actually a wee bit more discriminatory. Conventional wisdom has always been to stop thiazide diuretics in people who have this condition, but actually in our own cohort we saw no effect on calcium levels when bendrafluozide was discontinued, and actually there have been some studies done now looking at hydrochlorothiazide, which is the thiazide more commonly used in the United States, that actually show helpfully it reduces urinary calcium excretion. There's no significant increase in plasma calcium, and actually parathyroid hormone levels reduce on thiazide diuretics. So this actually might be a helpful therapeutic option rather than something we need to just jump straight to stopping, particularly in people with milder disease. So looking at evaluation now, the nice guidelines here suggest measuring vitamin D and replacing it. And I'll talk in a little bit more detail about that. As mentioned earlier, looking at urinary calcium to creatinine clearance ratio or some other method to exclude familial hypercalciuric hypercalcemia. They also ask that we consider symptoms and comorbidities, renal function, DEXA, and it's important in this context to look at the distal radius because that's actually the most discriminatory of the bone density sites in this condition, and also renal ultrasound, although that's maybe a wee bit controversial too, and I'll perhaps allude to that later. So this is another one of these things which seems completely counterintuitive, that if someone has a high calcium, you'd potentially want to give them vitamin D. And again, historically, the idea was that you would stop vitamin D replacement if someone presented with this condition. But actually multiple studies, albeit small ones, but when they're combined together in meta-analysis, it shows that actually there's no significant issue with vitamin D replacement. And calcium levels, there's actually a reduction in parathyroid hormone levels in most of these people. And the only note of caution would be 24-hour urine calcium. One caveat here would be if someone has markedly elevated calcium, we'd clearly be a wee bit more cautious about this. But in most people who we see in clinics, they have a borderline hypercalcemia or maybe a calcium of 2.7. And you can generally safely, in people who've got vitamin D deficiency, replace their vitamin D. FHH is obviously important because it's a disaster to send someone for surgery if they have this condition and not primary hyperpara. And I think there are a lot of issues around the interpretation of the tests here, which is why this is one of my hobby horses, is looking at the sensitivity of this investigation and this threshold of 0.0 less than 0.001. is the sensitivity is 80%, the specificity is 87%. And that's static, obviously, but actually the positive predictive value of this test is entirely dependent on the prevalence. And the prevalence is so heavily skewed towards primary hyperpara in people who present with hypercalcemia that actually it's hard to know what the prevalence of FHH is, but even at the most generous estimation, which would be a prevalence of about 0.2%, the positive predictive value of this test is 1%. And if you were to to say in a crazy hypothetical situation that the prevalence of FHH was 10%, the PPV is still only 41%. So essentially, having a test that looks like FHH in this population, you're still overwhelmingly likely to have primary hyperparathyroidism. And that is something that really isn't reflected in the international workshop guidance, which claims that it clinches the diagnosis. Even reputable information sources like Up to Date make similar claims. 18% of people who had surgically proven primary hyperparathyroidism that was cured had a calcium creatinine clearance ratio that would have been consistent with FHH. So my take home from this is genetics are really cheap now. And if there's any doubt whatsoever, just do the genetics. Genetics is not foolproof either, but it's going to be a much better test than this. It's not to say don't do it, but I think we just have to be careful in how we interpret it. There's a lot of talk about vitamin D levels being optimized before you interpret this test. We actually found that the levels were completely similar, whether you were vitamin D sufficient, insufficient, or deficient. It makes sense, of course, to replace, as I said before, and perhaps repeat. But a lot of the advice that's given about this isn't really based on very strong evidence. And there doesn't really seem to be any difference between a spot urine sample and a 24-hour collection, certainly in our hands. So genetics, some controversy maybe about the age threshold here, but under 45 years of age, about 10% of people will be found to have a germline mutation. Multi-gland disease would be another prompt, parathyroid carcinoma, atypical adenomas, which I have to say our pathologists increasingly report, family history, clearly, and clinical evidence of a syndrome. So if you someone with jaw tumours as well as primary hyperparathyroidism, for example, or a suspicion of FHH. And this is the form, or a version of the form in Scotland with the various panels you can do, panel for hyperparathyroidism, panel for FHH, with the various mutations that have been recognised. It's so easy to do this now compared to 10 or 15 years ago. So we have a very low threshold for asking for genetics. And the same panels are available in England now, I believe, as well. So I think it's relatively straightforward to get access to these. I'm going to skip, my slides are slightly disordered here. So obviously localization investigations should only be done if you're actually pursuing surgery. And I'll talk in a bit about where I think that should be done. But when I started training, the advice was, as been mentioned before, you don't really need to do preoperative imaging. You just need to find an experienced surgeon. It's certainly not our practice now, and I think most places will do some form of imaging preoperatively. We do ultrasound in Edinburgh, first line, and it appears as a first line investigation to perform as well as anything else. You'll see on the top panel here, in terms of identifying the correct location, it probably is similar or perhaps just slightly better than Sestamibi and SPECT-CT combined. The bottom panel is a slightly difficult slide, but essentially along the right-hand side there is looking at the rates of non-curative surgery. And as you might expect, those go up as you start to get to 4D CT, because essentially those are people where we've really been struggling with conventional imaging to find a tumour. And then if you look on the highlighted panel at the bottom, that's been looking at how many modalities of imaging an individual's had prior to their surgery. And again, it's perhaps unsurprising that if you've only required one modality, if there's been real confidence on ultrasound that you've identified a tumour, that the non-curative surgery rate is low, about 5%, whereas if you've gone all the way up to 4 modalities, it's about 33%. And this was in the era prior to us having access to PET choline scans. Unfortunately, we've lost our access to this at the moment in Edinburgh, and there are real difficulties, I think, in certain parts of the country getting hold of the time on a cyclotron to create the tracer for this. But our early experience, as I've just outlined here, data that's come from Dilip Patel in Edinburgh, is that PET choline CT is extremely effective. The accuracy is very high, about 88.9%. And that actually is in a group of people where there has been some difficulty in establishing the diagnosis. And experience from other centres, I think on the right-hand side there, that's a group from the Netherlands who've published. And again, pretty good results with this in terms of helping in the most difficult cases to localise tumours. More data from our cohort here. This is just showing the location of where most of the parathyroid tumours that were operated on in Edinburgh were found. About 2% were ectopic, 7% were multiple, and in 6% of cases, none were identified. And on the right-hand side there, it's just showing that there is a relationship in terms of the maximum tumour diameter and the levels of parathyroid hormone at diagnosis. So if you have someone who's got an extremely high parathyroid hormone concentration, obviously the type of people who are a bit worried about parathyroid cancer, then you're much more likely to see a larger tumour. And it might be surprising in the context of someone with very high PTH if you're really failing to see anything on imaging, maybe makes you want to think twice again. So yeah, to go back, I think, to probably where you have to begin before you think about doing scans to localise, the NICE guidance, it's not a million miles away from the international workshop guidance that had been mentioned earlier. It says to consider referral to surgeon where you've got symptoms like thirst, polyuria, constipation, so ones which are a bit more discriminatory, osteoporosis, fragility fractures, renal stone disease, and very high calcium, so calcium where it's more than 2.85 or greater than 0.25 above the reference range. And also to consider a bisphosphonate to reduce the risk of fracture. The idea that probably should be offering preoperative imaging and considering a second imaging modality to help to refine that approach, and then various different approaches based on whether you've identified an adenoma or whether there's a single adenoma, ectopic adenoma, or multiple. And what I would say from our own experience and from the data that we collected is that the risk factors for non-curative surgery were requiring more than one imaging modality, where the odds ratio of non-successful surgery was 2.4, and when we've not identified an adenoma on an ultrasound scan, where the odds ratio was 2.3. But the biochemistry wasn't predictive. So if you had a lowish PTH or a borderline calcium, that in and of itself was not necessarily a predictor of non-curative surgery. Moving on to the complications, because I think this is all important, and it maybe is a good opportunity to address the age question, because I don't think I mentioned it specifically in the slides, and it's not something that's prominent in the NICE guidance, but it obviously is another guidance. The cutoff of 50 to me seems absurd because it hasn't changed since 1990. To some extent, that must be related to life expectancy, because you're not going to operate on someone where you feel that they're not going to live for another 5 or 10 years. But if you diagnose someone with this condition, and as I'll hopefully show with some of the subsequent slides, there are potentially real dangers in this condition. It's not completely benign. If I were 60 and otherwise healthy, almost irrespective of anything else, I think I would want to have this cured. We could argue about that and ask questions later, but I think having an arbitrary age cutoff is a bit crazy. A lot of long-term follow-up shows that in mild disease, you have relatively static calcium levels for about 12 years, but after that, there does tend to be an inflection point where calcium levels rise. So I'd always argue that you're much better operating on someone who's 65 and healthy than waiting until someone's in their mid-70s and clocked up a whole bunch of other comorbidities with then very difficult to control calcium. But I think it is up for debate. The bone health evidence is actually surprisingly weak, given how common this condition is. A lot of observational studies, bone density is lower at the cortical than trabecular sites, although vertebral fracture risk is still increased. Bone density and microarchitecture improve following parathyroidectomy. And I guess it's important to say that the bone density isn't the only issue here, that there are things that DEXA scans can't pick up. They don't explain all of, or even most of an individual's fracture risk. There does appear to be a lower risk of fracture after surgical cure of this condition. But as I say, the number of, there are really effectively no decent RCTs to look at this. From our own experience, we looked at Z-score, it's looking at bone density corrected for age and gender. And the R values here at the hip, the femoral neck, and the lumbar spine, all strongly statistically significant except for lumbar spine. But the R value is, that's a weak effect size. So you're not really seeing a massive impact really based just on PTH levels alone. And when we looked at various different models for this, the things that were most predictive, so on the left-hand side are the kind of univariate analyses, and on the right-hand side, the multivariate, things that stand out as being independently predictive. So age, BMI, low creatinine levels, all things that would potentially speak to frailty. So lower BMI, older age, and lower creatinine, lower muscle mass. These were all things that really were much more likely to predict osteoporosis in this context than calcium or PTH levels. And a Z-score below 0, so you'd expect that to be 50-50, just by definition. And really, with the exception of the femoral neck, it was 50-50 in this population. So you're not really seeing a massive effect on bone density overall, I would argue. The independent predictors at the hip, low BMI, higher PTH there, but otherwise at the femoral neck and at the spine, indices of hyperparathyroidism like calcium and PTH weren't strongly associated. So I guess to summarize all of that, the evidence in terms of fracture risk is based on small studies, they're observational. There's not a huge amount of evidence for benefit available. I mean, there's small amounts of evidence, but nothing particularly strong there. And bone mineral density doesn't seem to correlate particularly strongly with the indices of severity of this condition. The idea, as is stated in most of the guidance, that you would use osteoporosis as an indication for surgery, I think is absurd, because if you have an 85-year-old woman with very mild primary hyperparathyroidism, she's almost certainly going to have osteoporosis, but it's almost certainly got nothing to do with the fact that she has this condition. So I think it's odd that these things persist through the guidelines, and I think we do have to generally be pragmatic about this. Nephrolithiasis, again, this is data from our cohort in Edinburgh. There was a prevalence of 14%. 10% had an established diagnosis of renal stones at the point of diagnosis. When we looked at imaging in 402 individuals with no prior history, there was 5% asymptomatic nephrolithiasis. Women over 50, 3%, women over 60, 2%. And I think the thing to point out here is data looking at the background prevalence of renal stones is 3 to 5% in women, it's 10 to 15% in men. So arguably, I would say in older women who are presenting with relatively mild disease, renal ultrasound is probably not necessary. And actually, our radiologists would argue it's not a very good test anyway for picking up renal stones. They tend not to be hugely happy doing it in Edinburgh because the pickup rate is relatively low. Predictors of nephrolithiasis, again, on the left-hand side, looking at univariate, and then on the right-hand side, things that stand out as independent and multivariate analysis. It's age and male gender, younger age, male gender. So men who are young, much more likely to have stones of this condition. Older women, much less likely. And calcium and phosphate, although there's an association with higher levels in univariate analysis, it doesn't hold when you add in the other factors. Moving on from stones specifically to just general morbidity in this condition, and one of the groups that have been most active in terms of publishing good large-scale observational data are the team in Dundee and Graham Lees, who just recently retired. This is a paper from last year where they looked, trying to adjust for most other confounders, and a suggestion that the diagnosis of primary hyperpara is associated with a slightly increased risk of cardiovascular disease, dysrhythmia, hypertension, fractures, osteoporosis, and kidney stones. On the right-hand side, so the table 4 here, when you had the opportunity to correct for vitamin D, not all of these associations persisted. Picked up some new ones, so there appeared to be a diabetes risk. the osteoporosis risk persisted, renal stone risk persisted, and they did also find that the risk of death was greater. I think there are major caveats to add to observational studies, because the likelihood is there are other unmeasured confounders here that are associated with some of this, why people might be getting blood tests done in the first place. So I'm not entirely convinced that primary hyperparathyroidism is responsible for a wave of excess mortality and cardiovascular disease, but I think it's definitely something that we need to bear in mind, because we don't have good outcome RCTs. We looked at mortality at a very simple level when you just look at people who were alive or dead at the end of our follow-up in the Edinburgh cohort. Obviously, age, lower BMI, socioeconomic deprivation, low vitamin D levels, and elevated creatinine levels, so kidney disease. These were all associated with an increased likelihood of death. Parathyroid surgery, very obviously associated with a much lower risk of death, but because we do surgery in people who are less frail, we don't do surgery in people who are frail. It might save lives, but I don't think anyone can really boldly make that claim. And if you look at a few survival curves here, this is in the complete cohort, people who did and who didn't have surgery, then you'll see the associations with calcium, parathyroid hormone category, whether people had surgery or not. That there are certainly some significant differences here, and some where there's a hint of a difference, but it's very difficult to untangle all of this. And I would suggest that a lot of the mortality is driven by vitamin D deficiency and frailty rather than necessarily the condition itself. So yeah, in univariate analysis, we found PTH to be a predictor, but not in a model where you included vitamin D deficiency. And because vitamin D and parathyroid hormone level are inextricably linked in terms of that relationship with whether one's up or down, I think it's very hard to draw any conclusions that this is a condition that increases the risk of death. There was a very striking paper from Dundee just over a decade ago, and that's in the lower panel here, and you'll see these wildly separate survival curves based on whether people had hyperparathyroidism or not. But you've got to conclude that that must be related to vitamin D and frailty rather than the condition itself, because I don't think that sort of relationship should be ever been replicated when you adjust for other confounders. So, as I say, very difficult to address just based on observational studies. I think that vitamin D sufficiency as a marker of frailty is probably the key thing here. And we absolutely do need large-scale RCTs, whether that's of surgical or medical management of primary hyperparathyroidism, to help resolve this better. And it's actually scandalous, given how common this condition is, that we don't have any data like that. But studies tend to get done where expensive medicines are available, and this doesn't qualify. Non-surgical treatment options, I think we're increasingly using cinacalcet in the sorts of situations that NICE suggest, which is where people have very high calcium with symptoms, so above 2.85 or above 3, whether or not they have symptoms. However, the evidence doesn't really suggest any major quality of life benefits with cinacalcet. It doesn't suggest any significant change in bone mineral density compared to placebo. And what you do get is sustained improvement in calcium levels. So the likelihood is you're going to improve the obvious symptoms of hypercalcemia, but you're probably not achieving much more beyond that. Bisphosphonates are to be considered in the context of fracture risk reduction, and they do improve bone density at the lumbar spine, femoral neck, and total femur, even in people with so-called normocalcemic primary hyperpara. And you'll see that there are sustained and significant benefits in bone density at the femoral neck and lumbar spine, but not in the study on the right-hand panel here and the distal forearm. And this is a big observational study from the United States from just over a decade ago that started to raise some question marks about bisphosphonate use and fracture risk reduction, because actually surgery was very clearly shown in this cohort, in this observational study, to reduce the risk of fracture. But actually, there seemed to be a signal here that bisphosphonate use may actually increase the risk of fracture in this context. Now, I think a lot of people debate whether that's a real phenomenon or whether it's related to selection of individuals. But it just does raise that question of whether conservative management is the right approach, where you've got the option of surgery and someone's otherwise fit for surgery. In terms of ongoing monitoring, I think particularly in people where a decision's been made not to pursue surgery, then to assess the cardiovascular risk, assess fracture risk, monitor calcium and renal function annually, to consider ultrasound if renal stones are suspected. Although I would say that if you genuinely suspect from a symptomatic perspective renal stones, then CTKUB would be better. If someone's on cinacalcet, then monitoring has to be more frequent to ensure that that's achieving its desired effect and you're not resulting in hypocalcemia, which is a possibility when you give someone too much, and to consider DEXA scan every 2 to 3 years. So I'll round up here. My main conclusions would be, firstly, not to rush to diagnose normocalcemic primary hyperpara. I think a lot of the time what it is either incipient frank primary hyperparathyroidism or someone who doesn't have primary hyperpara at all but has an elevated PTH and just needs more vitamin D or more calcium. I think most of the time we can treat vitamin D deficiency in the context of this condition, and maybe we shouldn't always be stopping thiazides, because if you reduce urinary calcium excretion, which those drugs do, then presumably you're also going to be reducing the risk of stones. I think we should avoid overdiagnosing FHH based on biochemical criteria, because you've almost certainly made a mistake if you've done that. And I think anyone where the biochemistry points to this, we should be looking at genetic testing. There are obviously other easy things you can do. If someone had a calcium 5 years ago, which was completely normal, and now it's high, well, it can't be FHH because their calcium would always have been high. If someone's got a very strong family history, because it's an autosomal dominant condition, makes it much more likely. I would say that the ultrasound of the neck is probably the best first-line imaging modality. But primarily, if you've got an experienced radiologist doing it, I think if you've got a whole list of different sonographers doing it, then that's probably not quite the same thing. I would have said PET choline, but given our difficulties locally, I'm not sure if the same thing's happening elsewhere, just difficulty getting hold of that test. I would always argue that we should have a relatively low threshold for surgical intervention because of the prospect of changing calcium levels over time, because of our uncertainty about quite how significant this condition is in terms of its risk of additional morbidity and mortality, and also all of the things we do clearly know about its risk of adverse effects on bone health and kidney stone risk. I think there's probably a long way to go in terms of how we optimally assess bone health in this context, because I don't think bone mineral density it is perfect, and certainly the relationship between severity of disease and BMD is not huge. The yield of abdominal imaging to look for kidney stones is really low, and it's very, very low in certain low-risk populations like older women. So I think we maybe do need to revisit whether that's necessary. And in general, evidence for medical therapies is pretty weak. Some of them will bring the calcium down. Bisphosphonates may help with fracture risk and it'll certainly improve bone density, but are we sure it's genuinely reducing the risk of significant fractures? I think we probably can't say that. What I do think we need is better national data collection, because that will help us inform clinical assessment, optimal investigations, and more about the morbidity and mortality associated with this condition. And like I said earlier, it's crazy to me that we don't have any RCTs looking at surgery versus observation, or surgery versus delayed surgery, or medical therapies versus observation, because it's such a common condition. And there is a signal there with a lot of the observational data that this is causing potentially significant harm, that we really should be doing a bit better research-wise. So with that, I will stop talking, and thanks for your attention.
Very much. Has anyone got any questions?
That's a great talk. I really enjoyed that. But you said we should have a low threshold for surgery. But in the previous talk, Professor Sabah said, keep a high threshold for surgery. So is that like, how do you address? I know you mentioned about we need RCTs and other things.
I think you can look at these data and you can potentially draw two completely different conclusions, and clearly people do. But I do think in some respects that's potentially a strength when it comes to our opportunities to do really good quality observational research, because I'm sure there are clinicians and centres out there with an extremely high threshold and an extremely low threshold. And in the absence of RCTs, it strikes me that if we had good ways of collecting data on outcomes across the UK, you might be able to start to address that and prove some of the things that we've hinted at in kind of weaker observational data. All I would say is if you were 60 years old and your calcium was 2.7 and you had normal bone density and no kidney stones, would you want this cured? I would say yes. Someone else might say no, but that's certainly how I feel about it based on the evidence that I've looked at. But yeah, clearly other people might draw different conclusions from that. And I suppose if you've not got clear evidence of a target in someone with mild disease, you're not going to rush into surgery. But I think where it looks like there's a very good target, I do have a low threshold.
Thank you very much. The points are well made. Tell me, do you think that this is underdiagnosed because the majority of people who get the condition are women in their late 40s and early 50s, and it gets confused for the menopause?
Yeah, I mean, I think it's possible, but I mean, there are definitely biological reasons why there's a gender split. And I mean, calcium gets checked so often now in the context of just general panels for tiredness and pretty much everything that I was alluded to before. This used to present with significant kidney disease and bony lesions, and now it gets picked up at the earliest stage. But as I showed in the first slide, it just gets ignored a lot of the time. And the first thing I do whenever I see someone in clinic is just go back over the 20 years of biochemistry that we have in our EHR, and you'll frequently find a high level before. And I think if we looked in depth at our biochemistry results across health boards, you'd absolutely see that we're not looking to diagnose it properly.
Well, this is what I mean, is that it gets ignored because the symptoms are ignored, and the calcium, that's just we'll ignore that. You've got the menopause, and that's why it's that patient group. And I frequently find that in the patients that I operate on, that actually they've been suffering for years and just been putting their symptoms down to the menopause because that's what they've been told.
Yeah, absolutely. And I didn't really focus too much on quality of life data because it's so mixed. And there's no good baseline predictive response. Although again, I think if we collected data better, we might be able to say something more about that. But yeah, clearly there are some people whose lives are transformed from symptoms perspective when they have curative surgery, and some people who have if it has no effect at all where you might have expected it to. It's very hard.
I mean, I must admit it's one of my favorite operations to do because the patients are so grateful afterwards. They literally describe it as sort of a curtain being lifted from them. This is that suddenly they can feel better, think better, sleep better. Very non-specific symptoms, but nevertheless has a massive impact on their lives. And you take a look at the patient parathyroid groups out there, and they, with some justification, feel hurt that this condition is being ignored, not just by the medical profession, but by politicians and everybody else. And so we really do need to work to bring this up. Yeah, now, we've got some online questions.
I was going to say as well, one thing we do, probably not without much of an evidence base, is we might give people an N1 clinical trial of cinacalcet to see if their symptoms improve with normalization of their calcium, and that's sometimes quite effective. But that's another thing where it would be ripe for a decent study.
Absolutely. I've got a couple of questions online. I think this is to Saba, but I'm not sure if he's still on. No. Okay. So if you're okay, I'll answer these ones. Will you consider removing abnormal parathyroid gland seen intraoperatively when you did thyroid surgery? My answer to that is no, not unless they had significantly elevated calcium preoperatively, which you should know as part of your workup. Just because you see something that looks abnormal doesn't mean it is. And if you're doing thyroid surgery, your biggest concern is hypoparathyroidism postoperatively and too low a calcium, which is also a significant patient impact. So no, I would not do that. Would you agree? Excellent. And then the other one is question Sabo. What is your experience with intralesional vitamin D injection into parathyroid adenoma in those who are unfit for surgery? Well, I have no experience of that. No, I'd never heard of it either. So I'll look that one up, but sorry, can't help with that particular question. Has anyone else got any questions they'd like to ask? There is one point I would like to make. You work in Edinburgh. You've got a fantastic radiologist who I can vouch for, does really good ultrasounds and describes exactly where the parathyroid adenomas are going to be. I use ultrasound predominantly to rule out any coexisting thyroid pathology and confirm the findings on the system EB. I like having the three-dimensional imaging to direct me to that parathyroid, and ultrasound doesn't give me that. It's very good at saying there's an adenoma there in the correct person's hands, but for surgical planning, having a SPECT or a 4D CT is incredibly useful to work out the relationship to other structures. So yes, dual modality investigation, but I use the thyroid ultrasound to confirm what has been shown on a CT, but also to rule out a U5 thyroid nodule that I might want to address at the same time, which does happen. Okay.
Good. I think we have, we're going to come back at 2 o'clock. So the local in-person audience is going to have a lunch. Then we work with the reps. There's some demos about bronchoscopes, channel endoscopes. So just spend some time with them. They'll appreciate that as well. And you will also learn more. We try to do with more practice there. Yeah. So we'll be back at 2 o'clock. So we